just share my screen. Yeah, and let me just swap. All right, can you guys see those slides?
Yes, look great.
Excellent. So I'm Shannon Nees. I'm one of the fetal cardiologists at Nemours. The sort of ask for this lecture was to go through some of the basics of fetal echocardiography. And I will kind of go over just generally sort of the indications for fetal echo, what we're looking for, some of the fetal physiology that we pay attention to, and then I'm happy to take questions at the end. And please feel free to interrupt me at any point if you have questions. So this is sort of the most recent guideline statement from 2023 from the American Society of Echocardiography. So this is sort of what we use as our standard for who needs a fetal echo and what views and things we're looking at. And I think this is a very helpful resource. It has a lot of beautiful pictures in it in terms of the different views that we try to get for fetal echo. So there, I pulled a lot of things from this paper for the purpose of this talk. So in general, when we think about the prevalence of congenital heart disease, depending on how you look at it, it's anywhere between 0.3 and 1% of the general population. So we sort of think about a fetal echocardiogram being indicated if the risk is greater than 3 times higher, but sort of where you set that risk depends on which data you're using. So does that mean if the risk is greater than 1% or if the risk is greater than 3%? And I think that this is helpful in figuring out why there's a difference between some guidelines in terms of who needs a fetal echocardiogram. And so I kind of break the indications for fetal echocardiogram into a couple of boxes. There are familial indications, which typically means a first-degree relative of the fetus. So that means either the person carrying the pregnancy or the father, siblings, or a prior pregnancy. Or if there are genetic disorders that have been identified in the family or the fetus, those can be indications. There are maternal indications, such as diabetes, and we'll talk a little bit more about those details. PKU, the presence of autoantibodies, certain drug exposures, certain infectious exposures, and then whether the fetus was conceived via IVF. And then there are fetal indications, which are typically the ones that we think about as the highest risk for having something. So the reason that we get many of our referrals is that there's a suspicion for congenital heart disease or abnormal cardiac function on their anatomy scan or on their first trimester screening ultrasound. And those are the most likely to have something abnormal when we see them. There are fetal arrhythmias. There are fetuses with extracardiac malformations where we know the risk of congenital heart disease is increased. Again, genetic anomalies, increased nuchal thickness, single umbilical artery, and we'll kind of go through some of these in a little bit more detail. So these are potential indications for fetal echocardiogram, and this is from that ACE paper, and I think this is helpful because it compares their recommendations, the AIUM guidelines from 2020 and the AHA guidelines from 2014, which was sort of the prior iteration of this paper. And you can see that some of them, there are some discrepancies. In terms of maternal factors, pre-gestational diabetes, the risk of congenital heart disease is 3 to 5%. So that's, still most of them will be normal, but that's pretty high. So that is indicated. If they have gestational diabetes that's diagnosed after the second trimester, that risk is essentially the baseline population risk. So those patients do not necessarily need a fetal echo. PKU has a really high rate of CHD. Autoimmune disease, we know those fetuses are at risk of arrhythmias in addition to congenital heart disease, so that is indicated. IVF is sort of a controversial one because of this risk ranges in different studies between 1.1 to 3.3%. And some of that may be related to other factors associated with IVF, like advanced maternal age and things like that. So the ACE guidelines say it may be considered. The AIUM 2020 guideline said it's indicated. And so we don't ever turn away patients who are sent for fetal echo for IVF, but I think it's sort of practice dependent whether people are routinely referred. And then there's maternal infections. As I said, congenital heart disease in a first degree relative is indicated. Second degree relatives, we often get these referrals, but the risk is very low, so they don't have to be referred. Um, Obesity is not an indicator, although if there's incomplete views, then often we'll see those patients for fetal echo. And then you can kind of, I'm not going to go through each of these, but they go through some of the different drugs and whether those increase your risk. And then the ones where you see really high risks of CHD are really the fetal factors. If there's fetal high drops, extracardiac anomalies increase your risk of CHD depending on the anomaly from 20 to 45%. Chromosomal abnormalities, depending on what they are, trisomy 13, 18 have really high rates of congenital heart disease. Monochorionic twinning, nuchal translucency. So if it's in that kind of borderline 3 to 3.4, that is around the baseline risk. And so they say fetal echo may be considered. But if it's greater than 3.5, that's where you really get that increased risk of CHD. And so that's where it is indicated. And then isolated single umbilical artery, this is also one that kind of went from maybe indicated to not indicated. A single umbilical artery with anything else starts to increase your risk of CHD. So this I thought is an interesting paper. So this was from, this is a study out of Columbia where they looked at fetal echoes that were done for an indication of extracardiac anomalies. So fetal echoes where there hadn't been congenital heart disease detected on the ultrasound, but they were referred for extracardiac anomalies. Or some, I think this also included ones where there was suspected CHD. But you can see that it varies significantly depending on what the extracardiac anomaly was. For musculoskeletal, about 25% of those patients had congenital heart disease. For CNS abnormalities, it was 16%. Craniofacial, there were fewer of those patients, but 35% of them had congenital heart disease. And so I think this is helpful data to have when you're counseling a patient who you see an extracardiac anomaly and you're referring for fetal echo. This kind of tells you the percentage for each kind of anomaly that are likely to have CHD. And what they did find is that even at this tertiary care center where the obstetric anatomy ultrasound included all the recommended views and they have really excellent obstetric ultrasounds, some of those screenings still missed quite a few of the cases of congenital heart disease. Most of those were VSDs and coarctation of the aorta, which are difficult to diagnose prenatally, but the fetal echo still added value. And so even in the ones where the OB scan didn't see anything concerning for the heart, they still were finding congenital heart disease in some of those. So it sort of justifies doing the fetal echo. And then this is another study. This is a postnatal study using the kids inpatient database, which is a multi-institution database of inpatient data from centers across the country. And this was sort of a similar thing, but not based on fetal data, looking at non-cardiac congenital anomalies and then their risk of having congenital heart disease and kind of breaking it into severe and non-severe. And again, there's variation. Cleft lip and palate, about 16% of those had congenital heart disease, and that's often associated with like 22q11 deletion or other genetic syndromes. Respiratory malformations had a really high rate. Urinary malformations have a pretty high rate of congenital heart disease. And so this is why when we see those extracardiac anomalies, it makes sense to get a fetal echocardiogram to really examine the heart. So sort of why does congenital heart disease happen? We know that this is multifactorial. It can be related to chromosomal or other genetic syndromes, teratogenic influences, infectious disease, metabolic disorders, and then it can be familial. So I'm the director of our cardiovascular genetics clinic, in addition to being a fetal cardiologist. So this is like really what I get excited about. But how do we know that there's a genetic basis for congenital heart disease? We know that because in the general population, congenital heart disease occurs in about 1% of the population. But if you look at recurrence in offspring of parents who have congenital heart disease, that risk increases to 3 to 20%. Recurrence in siblings overall, like all congenital heart disease, is about 3%. So that's the number I give patients when their fetus is diagnosed with congenital heart disease. Sort of the risk of recurrence in a subsequent pregnancy is about 3%. But it depends on the type of congenital heart disease. So for example, left-sided obstructive lesions, those are much more likely to have, this breaks it down. If the father's affected, the mother's affected, or there's a sibling, that really increases your chance of having another child with some type of congenital heart disease. It might not be hypoplastic left heart, it might be a bicuspid aortic valve, but the chance of having something can be as high as 10%. So I sort of tailor my counseling for subsequent pregnancies based on the type of congenital heart disease that we see. And then we talked about these, but there are multiple different maternal factors that can predispose to congenital heart disease. And this is a very old study from 1987, but looking at sort of some different drugs and the risk of congenital heart disease. And as I showed before, the ACE guidelines have sort of updated data on some of these. All right, so now that we've kind of talked about who should get a fetal echocardiogram, the next question is when should that happen? So optimal timing is between 18 and 22 weeks gestation. At that point, the heart is large enough to see detail. The ribs are not as dense as they will be later in gestation, so there's not as much shadow artifact. And usually between 18 and 22 weeks, the fetus is kind of moving around and flipping. So even if they're not in an ideal position at the beginning of the scan, the likelihood that they might move into a better position throughout the course of the scan is much better. They can be performed as early as 12 to 14 weeks. Usually I sort of think 14 weeks is better than 12 or 13 in terms of your chance of getting good images. And these early fetal echoes are used in fetuses that are at the highest risk for cardiac abnormality based on familial factors, prior pregnancy. So we will often offer this if the family has had a prior child with congenital heart disease, or the family has Noonan syndrome or something where we know the fetus is at very high risk, especially if the family might change their pregnancy management based on those findings. But it has to be repeated later in the second trimester, even if it appears normal. So it's helpful if you find something very abnormal. If you see that there's hypoplastic left heart at 13 weeks, you can be confident that that is what the fetus has. But if it looks normal, it just isn't as good of resolution. So I always have them come back around 20 weeks for a repeat. And then when we find something abnormal on a fetal echocardiogram, we do serial assessments. And depending on what those are, those usually happen between 2 and 8 week intervals, depending on the lesion and whether it's likely to sort of progress throughout the pregnancy. And usually, there are some exceptions always, but after about 34 or 36 weeks, it's just very difficult. Especially if the fetus is in a bad position, the bones are more calcified, it's harder to see the heart. So usually we kind of stop around 34 to 36 weeks and then say, after that, we're going to get a postnatal echo and we'll see what we're dealing with at that time. Factors that impact the quality of the fetal echo are the same as I'm sure impact the quality of all of obstetric ultrasounds. Maternal obesity can be a challenge. Either polyhydramnios or oligohydramnios can make it difficult. If the patient has had prior abdominal surgery and there's a lot of scarring, that can make it difficult to see the images. And then the fetal position. Sometimes the baby is really curled up, that can make it difficult to see the aortic arch. And if they're moving around a ton, sometimes it could be hard to get the cine clips that we need. So now we've sort of gone through who gets the echo when. So now what are we actually looking for? So there are multiple different views that we look at, some of which are included in a detailed anatomy scan, but others of which are not. So we start with an axial sweep from the stomach up to the upper mediastinum. That sort of goes through the four-chamber view of the heart, the arterial outflow tract. So we look that the outflow tracts cross each other and are normally related, and then all the way up to the great vessels and the arch views. We then focus on a four-chamber view, both with 2D and color Doppler to assess the valves. We look at the left and the right ventricular outflow tract, again with 2D to look at the actual valve morphology, with color Doppler to look for any evidence of stenosis or regurgitation in the outflow tract or across the valve. And then we Doppler both the inflows in the four-chamber view, so the tricuspid and mitral valve, and then the outflows as well. We do a 3-vessel view and a 3-vessel trachea view, again with 2D color and Doppler. And then we also do sagittal views of the aortic arch and the ductal arch, as well as some other sagittal views. And all of our clips, for the most part, are cine loops. So we very rarely do 2D clips. So for the most part, we're doing cine loops as the heart is moving, as the vessels are moving, as the valves are opening for our 2D, for our color, and then we do Dopplers. So these images are from that ACE guideline. As I mentioned, they have just these nice, pretty pictures. So this sort of goes through the different axial planes that we're looking at, starting inferiorly, where we're looking to make sure that the stomach is on the left side. We sort of always start with, even before these axial sweeps of the heart, I always start with a situs sweep, which goes all the way from the baby's head through the feet. Well, I always start inferiorly on the maternal abdomen with my notch on my transducer at 3 o'clock and then sweep up. If the baby is in a straight vertex or a straight breech position, you can figure out what's left and right based on always having your transducer with the notch at 3 o'clock. I use what we call the Cordis method for determining situs, which is where you then put the notch towards the fetal head and then turn 90 degrees clockwise, and sort of wherever the baby is, if you do that maneuver, it makes it so that the image appears as if the baby is breeched. So the butt is coming out of the screen and the head is going in. And then you can determine which side is right and left based on the position of the spine. So I use that method in all my patients, just because it's not dependent on what position the baby is, and I can always figure out what's right and what's left. Usually the stomach's on the left side, but in some of our patients, they have situs inversus totalis, and so you might be fooled if the stomach is on the right side and the apex is on the right side. You can't sort of use that as a landmark. So once I know where the stomach and the apex are, then for the rest of the scan, I use that as my landmark. So I say, okay, I know the stomach's on the left, so even if the baby's doing somersaults, I can reorient myself to where the left and the right is. So then as we go up more superiorly on the baby, we start with the stomach. We get the 4-chamber view where you see the right atrium, the left atrium, which is the most posterior structure closest to the aorta, the right ventricle, the left ventricle. And then as you go up, the next thing you should see is the left ventricular outflow tract. And then you see the right ventricular outflow tract. The pulmonary valve should be more anterior and leftward than the aorta, and it should cross over if they're normally related. And then as we keep going up, we get into that 3-vessel view where you see the SVC, the aorta, and the pulmonary artery, and then up to the SVC, the aorta, and then the ductus arteriosus coming from the PA and connecting to the descending aorta. And normally the aorta and the PA should be on the left side of the trachea. So that's sort of our axial views. And then we do sagittal views. So we do a bicaval view, and I apologize, these are small, to look for the SVC coming into the right atrium and the IVC going through the liver into the right atrium. And then we kind of starting from our 3-vessel view where you see the SVC, the aorta, and the ductal arch, we want to basically take sort of modified sagittal views to get each of those arches. So if you can line up your transducer so that the aorta is right in the center on an axial and then turn 90 degrees, you should get this very nice sagittal view of the aortic arch that looks like a candy cane. And then the same thing if you kind of move over on the baby to where you have the ductal arch lined up and then turn 90 degrees, you should get this nice ductal arch view where you have the RVOT and then the ductal arch, which is described more as a hockey stick. And then we do short axis sweeps through starting where we see the aortic valve sort of en face with the RV and the MPA, and then we look for branch pulmonary arteries to make sure that those are confluent. And then as we sweep through, we see the right ventricle and the left ventricle. We're taking cine clips, so we're watching the ventricular function. We're looking to see, does the RV look more dilated than the LV, and all of those things as we sort of go through. Any questions about that so far? All right. So these, again, these are from the ACE guidelines. So in addition, most of this stuff is sort of describing the anatomy that I just went through. We're basically looking for each segment of the heart. So do the systemic veins come in normally to the right side? Does the RA go to the RV, to the pulmonary arteries? Do we see pulmonary veins coming back from the lungs into the left atrium, left ventricle, aorta? So we're looking at all of those. Are they connected normally? Are they related normally? In addition to all of that anatomy, we're looking at the cardiac size, the axis, is it pointed with the apex to the left, the position in the thorax, and then we look at the visceral situs determination, so making sure that the stomach's on the left and the liver is on the right. All right, so cardiac embryology requires a whole separate lecture, but the point that's important for thinking about fetal echo is that the heart is fully septated and formed by around 7 to 8 weeks of gestation. The intracardiac structure is determined, and so really we're waiting for it to be big enough for us to image. So it's not that, we wait till 18 weeks because that's when the heart is fully formed. It's just that that's when we can see it. So then I'm going to talk a little bit about the fetal circulation and then how we kind of assess these different shunts on a fetal echo. So I'm sure you all know this physiology, but fetal blood is oxygenated in the placenta. It returns to the fetus via the umbilical vein and then goes through the ductus venosus, which is the first shunt, joins blood coming from the IVC, goes into the right atrium. That oxygen-rich blood from the ductus venosus is preferentially shunted across the foramen ovale, which is our second shunt, to the left atrium, left ventricle, and then that highly oxygenated blood is going to the ascending aorta and up to the baby's brain. So this is all designed to kind of get that most highly oxygenated blood up to baby's head. Blood from the SVC and from the IVC come into the right atrium. Some of that blood is going to go into the right ventricle and across the pulmonary valve, out the pulmonary artery, and then across that third shunt, which is the ductus arteriosus, and into the descending aorta. And so we have the ductus venosus, the foramen ovale, and then the ductus arteriosus. So these circulations, the right ventricular and the left ventricular, are in parallel. Whereas after birth, when these shunts close, they are in series. The right ventricle in fetal life is the dominant ventricle. It ejects 55 to 65% of the total cardiac output. And only about 10% of that flow goes to the pulmonary bed, right? Because the lungs are collapsed, the baby's not breathing. So there's only a small amount of blood that goes to the pulmonary arteries and then back to the pulmonary veins. Most of the blood that's coming from the RV into the PA goes across the ductus arteriosus and then down to the descending aorta and eventually back to the placenta through the umbilical arteries. The left ventricle blood, in addition to supplying the fetal brain, also supplies the coronary artery. So that is another reason that highly oxygenated blood is good. And then we, as part of fetal echo, we also do biometrics. So things that we're looking at is the heart rate and the rhythm. We usually assess the heart rhythm doing an inflow and outflow Doppler in the left ventricle. So this is where you can see the mitral valve inflow and the aortic outflow in the same Doppler. And so you should see this E wave and the A wave in the mitral valve inflow and then this aortic outflow. And you can see that for every E and A wave, there's one outflow. So it's sort of one-to-one. Atrial contraction is where we see the A wave, and then ventricular contraction is when we see the outflow from the aorta. So we can assess that there's normal rhythm based on these Dopplers. Oops, sorry about that. We also measure all of the valves, so the aortic, pulmonary, mitral, and tricuspid valve. Those are helpful. We use Z-scores based on gestational age to say whether those structures are normal size for gestational age or too small or too big. And it also can give you a hint if there's size discrepancy. If the tricuspid valve Z-score is 1.9 and the mitral valve Z-score is negative 1.9, then there's clearly something discrepant about those, even though they're both technically within normal limits. And so that can be a hint that something's going on that's causing size discrepancy. We also look at the cardiothoracic ratio. This is one thing where cardiologists and MFMs and obstetricians differ. We usually use the cardiothoracic area ratio. So we're taking the area of the heart over the area of the chest. And the normal for that is less than 33%. So essentially the cheat is you should be able to fit 3 hearts kind of within the chest. And if it's bigger than that, then that's considered cardiomegaly. If you use, most OBs and MFMs report a circumference ratio, so the circumference of the heart over the circumference of the chest, and normal for that is less than 0.5. So you just have to make sure you know which cardiothoracic ratio someone is reporting to know what the normal is. And then these are just some examples of how we measure the different valves and the different arteries while we're doing a fetal echo. There are additional measurements for cardiac function that we don't necessarily do on every single patient, but we'll do if something looks abnormal. So you can measure the thickness of the ventricular walls. You can measure the actual shortening fraction as a measure of how the ventricles are squeezing. There are ways of measuring RV and LV volumes to try to estimate an ejection fraction, although it's a little difficult to reproduce these in a fetus. And then we can also estimate the combined cardiac output, which essentially looks at the flow across the aortic valve and across the pulmonary valve, multiplied by the diameter of those and the heart rate. And that basically tells you the overall flow that's coming out of both sides of the heart. And since they're in parallel, you really need to measure both to have an idea of how much blood the heart is handling. And that can be indexed to estimated fetal weight. We don't do this for every patient, but when there are high output lesions, like vein of Galen malformations, abscent ductus venosus, things like that, we'll follow this throughout gestation to see if it's changing. And then we also do kind of routine Dopplers. So these are from the ACE guidelines. We are required to do an umbilical vein, a ductus venosus Doppler, pulmonary veins, the inflows, the outflows, the ductus arteriosus, and then the umbilical artery. And then depending on what we're seeing and what the fetus has, we may do additional Dopplers as well. All right, so talking a little bit more about these fetal shunts, and I know I only have a couple minutes, so we'll go through this very quickly. The ductus venosus is a really important structure. This joins the umbilical vein with the IVC as it enters the right atrium. It is slightly constricted, so usually you can find it by what's described as the sparkle or aliasing. And you want to see that it's coming from the umbilical vein, and then that blood is being directed to the IVC and into the right atrium. You can see it on a sagittal and also an axial view. This is that little like sparkle that people describe. The normal ductus venosus Doppler has an S, a D, and then a nadir with the A wave. Absent or reversed A wave is a sign of fetal distress. Can be associated with IUGR, poor RV compliance, right heart lesions, and arrhythmias. So is abnormal. You can have agenesis or absence of the ductus venosus where you don't get that restriction of flow, and that can be an example of a high output lesion. And then the second shunt is the foramen ovale. This is a communication between the left and the right atrium. Normally that flow should be right to left, directing that oxygen-rich blood across to the left atrium. That handles about 30% of the output. And you can have premature closure or restriction of the foramen ovale, which is rare. But it can affect the hemodynamics. It can cause small left-sided structures, leading to an RV-LV size discrepancy. And if it's really bad, you can get right heart failure. And this is just an example. Here is the atrial septum. This is the right atrium, the left atrium. You can see that this atrial septum is thick and it's really bowed over towards the left. And with color, there's like this little aliasing of flow where it goes across. So this was a restricted foramen. And this fetus presented with RV-LV size discrepancy with the left ventricle smaller than the right because of that restriction. I'm going to skip through this. This is important in some types of congenital heart disease to really look at this. And then the ductus arteriosus is that last shunt that receives the majority of the RV output. As fetuses advance, there is narrowing of the ductus arteriosus, so the normal velocity can get higher. But this is a normal flow pattern. So you see that nice systolic peak and then some continuation of flow in diastole. If the velocity is higher, that can be associated with flow restriction, which can lead to right heart failure in a fetus. All right, and these are just some more of those pictures that I showed, which I'm going to skip through, and sort of our normal Doppler assessment. As I mentioned, we look at the UA, the UV, which you guys are familiar with assessing, so we'll sort of skip through those for now. And then there's lots of different ways of doing functional assessment. Typically, we don't do these on every study. For the most part, we're looking just subjectively at how the ventricles are squeezing. But you can measure things like the myocardial performance index, where you're looking at the inflow and the outflow Doppler, the same thing we showed for rhythm. And you look at the time in between those, and you can get a measure of flow, a measure of function. And as you start to see if that mitral valve inflow becomes monophasic, that is associated with worse ventricular function. All right. And then there are, of course, like every test, limitations. So based on the size of the fetal heart and differences in fetal physiology compared to postnatal, we can miss small septal defects, mild valvar abnormalities, partial anomalous pulmonary venous return, hopefully not total anomalous pulmonary venous return, because we usually look for one right and one left pulmonary vein joining the left atrium. We cannot see the coronary arteries on fetal echocardiogram. Because the ductus arteriosus is patent after birth, sometimes as the ductus arteriosus constricts, the isthmus of the aorta can constrict and cause a coarct that we might not be able to see prenatally. And then obviously we can't predict whether the PDA will close normally. And then all those shunts have to close immediately after birth for babies to make appropriate transition. And so that is important, and that's then where we as the cardiologist come in after birth to assess. So in summary, ultrasound of the fetal heart is very useful, especially in patients at risk of having an infant with CHD. Prenatal diagnosis can improve preoperative mortality and morbidity. I didn't really go into the data, but there is data to support that. A detailed echo followed by thorough counseling helps families kind of understand their options for a fetus with congenital heart disease. And then when there's an abnormality on the obstetrics scan, those are all reasons to suspect congenital heart disease. And so we as fetal cardiologists like to think that we sort of give the families as much information before birth. So when they have a baby with congenital heart disease, they're sort of prepared and they know what to expect after birth. So thank you guys so much. And I would be happy to take any questions.
Thank you so much. It was very helpful. Thank you.
Questions? All right. Well, thank you guys so much for having me. Either myself or one of my colleagues will be back later this spring to talk about left-sided obstructive lesions. And we're always available. Feel free to reach out to me via email if you have questions about patients or anything.
Thank you.
Thank you.
Thank you so much.
Bye.